Well, hello, everyone. Happy Tuesday. Good afternoon. I would like to officially welcome you to today's Mind Opener on Geographic Disparities in Healthcare, sponsored by Blue Cross Blue Shield of Minnesota. I'm Luna. I'm the Policy Director at Citizens League, and I'll be moderating today's conversation, but we're going to do a few things first and then dive in because we have an amazing panel and a robust conversation for you. Attendees will probably continue to trickle in, but let's get it going. To begin, I'm going to welcome Lynn Nelson, Vice President of Public Affairs with Blue Cross Blue Shield Minnesota, to start us off.
Thank you, Luna. Hello, everyone. My name is Lynn Nelson. I serve as the Vice President of Public Affairs at Blue Cross and Blue Shield of Minnesota. I am incredibly pleased to welcome all of you to this important discussion on geographic disparities in healthcare access. And I want to first say thank you for joining us. Blue Cross has been a longtime sponsor of the Mind Opener series, and we are proud to support the work of the Citizens League. And they have pulled together a powerhouse panel on a topic that is really important. Blue Cross serves members in all 87 counties, which really gives us a unique perspective and opportunity to work collaboratively with policymakers, researchers, providers, and community members to identify and address urgent and emerging issues in rural healthcare. For more than 90 years, Blue Cross has been a trusted partner to our members, providers, and community leaders in ensuring that access. We really value that trust and work hard to keep it. Today's topic is top of mind for us as we work to ensure members can access affordable and high quality care, regardless of where they live. So I appreciate you all being here, and I think now I'm going to turn it over to Jake.
Thanks, Lynn. We're so grateful for Blue Cross's continued support and partnership, and especially for sponsoring today's conversation. My name is Jake Loesch, and for those of you who are not familiar with me or the Citizens League, I have the privilege to serve as our executive director, and I'm so glad that you're all joining us today. A special welcome to anyone who's joining Citizens League for the first time, and of course to our expert panelists today. For those of you who are not familiar, Citizens League is a 72-year-old nonpartisan nonprofit organization here in Minnesota. We have been focused on civic engagement and building trust and connection across difference to find pragmatic public policy solutions since 1952. Today, our work includes the Capital Pathways Internship Program, which will be celebrating its 10th anniversary in 2025, creating paid opportunities for BIPOC college students to work with host organizations and gain direct experience working in the legislature and the public policy-making process. We also conduct public policy research and studies, and our current projects include researching workforce challenges and opportunities in local government in partnership with the League of Cities and the Association of Counties. And we're also exploring traffic stop data in Minnesota, working with law enforcement to better understand what information is collected about stops at the 400 plus law enforcement jurisdictions and agencies across our state. And with generous support from the St. Paul and Minnesota Foundation, we're looking at recommendations and opportunities to better understand why people are getting pulled over in Minnesota. And this builds off of some work that was recently piloted by Ramsey County. And finally, we also host regular events, just like today's conversation, deep dives into public policy topics, creating educational opportunities, and hopefully helping all of our attendees hear from a variety of perspectives, ideas, and take away some learnings back to your own lives and work. We do have a few other upcoming events, including one tomorrow on nursing homes and elder care in our Interconnected series with the Center for Rural Policy and Development, as well as an in-person event on the evening of November 25th, which is in partnership with NPR News Talking Sense series, when we'll dig into coming together to solve tough problems with the authors of a new book out this year called From Conflict to Convergence. You can find information about these and other future Citizens League events on our website at citizensleague.org/events. So with that, I just want to say thank you all again for coming today. Really excited to dig into this conversation. And I am going to hand it over to my colleague, Luna, our policy director, to take away the panel. Thanks again.
Thanks, Jake. Well, welcome again, everyone. Panelists, you can start to come out from behind the curtain. It's like magic. And I'll just get us started by, again, saying thank you to those who are joining us from Minnesota or perhaps beyond. Please feel free to put questions in the chat or in the Q&A function. We will try to get to as many questions as we can, but we've got a lot to talk about. So as we all know, Minnesota has a wide and diverse population with unique healthcare needs in different jurisdictions and across populations and systems and histories. So today we're talking transportation, identity, economics, cost, and beyond. And we are lucky to be joined by this stellar panel to discuss this more deeply. And what I'm going to ask is, to start us off, if each of our panelists could briefly introduce yourself and your work and or your studies and research, and answer the question, how do you define or describe healthcare? And what role do you and or your organization play in helping people statewide, particularly in rural Minnesota, access care? So I'm just going to go with whoever's to my right, and if you could do the same, whoever's close to you. Senator Rasmusson.
Great. Well, good to be with you all today, and I'm looking forward to the conversation. I serve in the Minnesota Senate and represent 5 counties in west central Minnesota, so a fairly rural part of the state. I live with my wife, Emma, in Fergus Falls. I would say the committees that I interact most with healthcare on would be the Senate Commerce Committee, which serves as a regulator of sorts, really, and thinking about the framework for healthcare in Minnesota. And then also on the Minnesota Senate Human Services Committee, which in a lot of ways is one of the largest providers of healthcare and also one of the largest funders of healthcare in the state when we look at our medical assistance population and the other work that DHS and direct care and treatment do. Before I ran for the legislature, my background was as a healthcare private equity investor. And so I did a lot of investments looking at healthcare businesses in that ecosystem. And so I found that that experience has been really helpful in navigating the complexities of healthcare. And I think, if you talk to a lot of Minnesotans about maybe their frustrations with healthcare, they'll talk about just the complexities of who's paying for what and what the price is and where I can access something. And I think it's a unusual service when you look at other services we have across our economy and just the complexity. But on the other hand, it's also one that pretty much every Minnesotan engages with every year in some way, shape, or form. And so it's really important to get right. It's a big and increasingly bigger piece of both the Minnesota economy and our state budget. And so especially down at the state capitol in St. Paul, I think healthcare is going to continue to be a bigger and bigger topic going forward. And for me, Luna, to go to your question of how do you define healthcare, for me, it's really the system of services, payers and providers that come together to provide health services to the Minnesotans who need it. And really, it has to be about the patients at the end of the day, but a lot of stuff has to come together in order to have good patient outcomes. And that's where the conversation will hopefully be today.
Senator Hauschild, now you're to my right. Do you want to go next?
Excellent. Well, thank you so much to everybody. Thanks to Blue Cross Blue Shield and the Citizens League for holding this panel. I'm really excited to be a part of it. I'm Grant Hauschild. I'm the state senator from the most rural district in the state of Minnesota, the entire Arrowhead in the northeast corner of the state. I have the Iron Range, the North Shore, 65% of the Canadian border of Minnesota. I also have 2 tribal nations in my district. So it's a really, really regionally diverse district. It bumps up against Duluth. And I also work in healthcare. I work for Essentia Health, which has a health system sort of across rural and greater Minnesota, northern Wisconsin, and into North Dakota. My wife and I moved to northern Minnesota for her career as an advanced practitioner in healthcare. And I used to do healthcare fundraising where I raised money for patients and families that maybe couldn't afford certain aspects of their care. The thing that I'm most focused on in my work as a legislator is what I call the rural tax. All of the compounding effects that happen in rural communities that disadvantage us when it comes to quality of life and well-being. And that gets to really the way that I define healthcare, which to me is well-being. It's about how are we making sure people are living the best quality and healthy lifestyles that they can. And that's everything from the trauma and direct healthcare that they need, but also things like mental health, things like having a roof over their head, childcare, all of the things that go into living promoting a quality and well-being lifestyle that I think improve all of our lives. So that's really my focus. I serve not really on any healthcare committees like Senator Rasmusson, but again, I've been really focused on how outcomes in rural communities impact us in a couple of key areas like emergency medical services and mental health. So really interested in this conversation and diving in. Thanks so much for the opportunity.
Thank you. I've got Ravyn next.
Thanks, Luna. Bujuaning. Good afternoon, everyone. My name is Ravyn Gibbs, she, her. I'm Ojibwe. I'm from the Bois Forte Nation with family ties to Red Lake. I was born and raised in Duluth, Minnesota, actually coming to you from my homelands and my family home in Duluth right now. So I'm happy to be here. Thanks for the invitation. As I mentioned, I'm Ojibwe. I'm a public health social worker. I'm also a doctoral student at Johns Hopkins. And I bring all of these lenses with me as leading the tribal relations work as a tribal liaison at the Minnesota Department of Health. So I'll be answering these questions through that lens. So in terms of healthcare, healthcare for Native people is a system that reinforces tribal sovereignty. It strengthens tribal health systems and secures resources to achieve the highest level of health and well-being. In addition, healthcare for Native people also includes a nation where comprehensive personal and public health services are available and accessible to urban Native communities. We have 3 large and vibrant urban Native communities here in Minnesota. In terms of access to care, especially rural health care, I think it's really important to remember that tribal health care is also rural health care. These nations face very similar challenges that we see in rural communities. They are generally in rural communities. At the Minnesota Department of Health, we play a crucial role in ensuring that people statewide, especially in rural areas, have access to quality health care. We do that in ways of promoting telehealth, supporting rural health workforce, improving access to care, advancing health equity, and collaborating with partners to achieve this health system. And as a tribal liaison, of course, it is my role to help the agency to implement Statute 1065, which is that government-to-government relationship between tribal agencies and tribal nations. So really ensuring that our tribes are part of the table in large decision makings, especially issues that have tribal impact.
Thank you so much. Dr. Henning-Smith, you're next to my right.
Hi, everyone. I'm also really glad to be here. I'm excited for this conversation. I'm Carrie Henning-Smith, she, her pronouns. I am an associate professor in the Division of Health Policy and Management in the University of Minnesota School of Public Health. I also co-direct the University of Minnesota Rural Health Research Center. And my research and teaching focuses on rural health equity, on aging and long-term care in rural spaces, on access to care and workforce, and on social drivers or social determinants of health for rural residents. I also sit on the board of directors for CentraCare. We heard about Essentia already. CentraCare is another one of our big rural serving health systems in Minnesota. And in terms of how I define healthcare, I think it's just telling that we all have different definitions. It's not that easy to define. I have a PhD in health services research, and I would have a hard time coming up with a very clear definition because it touches so many parts of our lives. It's clearly all of the clinical care that we receive. It's interfacing with providers, with payers, with systems, as we heard about before. But it's everything else too that impacts our health and our quality of life. And I think it's important for health systems and healthcare providers to know what their lane is and then where they need to partner and find collaboration and where they need to actually be intervening in terms of housing or transportation. And I know our conversation's going there today, but I'm looking forward to that.
Wonderful, thank you. And to close us out, Dr. Hart.
Hi, great to be with everyone today, and real pleasure to be a part of this panel. My name is Dr. Brett Hart. I'm the Vice President of Behavioral Health and Mental Health Parity at Blue Cross Blue Shield of Minnesota. I began my career as a clinical psychologist, but have worked in the insurance industry now for 25 plus years. Blue Cross Blue Shield of Minnesota is one of the first of what's now 33 independent Blue Cross companies across the United States. We insure about 2.5 million members throughout the state of Minnesota. And as a nonprofit health plan, we're present in all 87 Minnesota counties. We have been headquartered in Eagan for about 50 years now, and have a strong commitment to the community and to the state as a whole. I probably don't have a lot to add in terms of how we define the healthcare system, because I think it's been described very well by the other panelists. I would just reiterate the fact that it's definitely a very multifaceted and highly matrix system. And I would suggest that for healthcare to work overall, all the component parts of that healthcare system have to work extremely well. So it's important that we understand what those components are, what needs to happen in order to optimize each.
Thank you all so much. Dr. Hart, I'm going to stay with you for our next question. We probably could have an hour panel or a multi-day panel just on language, as all of you mentioned in talking about health. We hear terms health, healthcare, health insurance, healthcare access, mental health, physical health. So I'm wondering if you can talk a little bit about healthcare access and what that means when we are hearing about services or systems that are essential in accessing healthcare. So as we start this conversation, particularly about access, and think in particular about rural communities in Minnesota, what are some of those tenets we should be thinking about?
Well, thank you for the question. When I think about access, I think first and foremost, it's such a broad concept, and I believe it goes well beyond a simplistic notion that it pertains to just having a provider available in your area. I think when we talk about access and what constitutes high quality access, there's a few components. I think first of all, we have to attend to ensuring the patient's preferred medium for receiving healthcare is available. Do they prefer to receive their care in person? Do they prefer virtual, tele, digital? So the medium through which care is delivered. Second, I think another real important part of quality access is that there's a repeatable source of care that allows the patient to develop a relationship. That relationship and continuity is a critical part of effective care. It also involves timely availability. And then I think fourth, I'd mention the importance of health insurance to facilitate entry into the healthcare system. But in terms of the basic services or systems that are essential in accessing healthcare, I think there's, and I'll mention these very quickly, but I think there's really six. There's a good general practitioner network, which is so critical for things like preventative care, screening, routine treatment. Second is the necessity of specialty services, and this is really important in rural areas where many of these services may not be readily available. Third is the importance of emergency services. But in a system where there's minimal access to primary and specialty care, those first two components, there begins to be an over-reliance on the emergency services. So, you see where the first two become especially important. And then to round it out, I think the three other critical components are support services. So I would include in that things like pharmacies, rehabilitation services, home health. Fifth would be health insurance systems. And then sixth, and I wouldn't want to understate the importance of number six, which is health information systems, ensuring that we have strong communication throughout and within the healthcare system to communicate patient histories, healthcare needs, what's worked, what hasn't worked, things of that sort. So a lot of components there, but I think all of them are critical in understanding the overall intact system.
Absolutely. Thank you for breaking that down into those 6. That's helpful for me. Hopefully, attendees, you are nodding in agreement. But it makes sense that we need providers, we need appointments, we need a way to get there. We need insurance or access to care if we're uninsured, to cover the cost of care. Ravyn, I'd love to go to you next. Can you expand a little bit on our perspective about healthcare access as a Native woman, social worker, public health researcher, additions that you have when we're thinking about access, particularly in the work you do with tribal relations?
Absolutely. Thanks, Lina. I really think healthcare access in Indian country is deeply intertwined with the unique experiences of tribes and American Indian people, especially that they've been shaped by historical injustices and ongoing structural inequities. Of course, we know in terms of the historical injustices, the many harmful federal Indian policies, including forced relocation, and as we know, boarding school era has led to significant health inequities. We know that there are policies that have resulted in structural racism, which leads to a disconnection from community and culture and distrust between tribal nations and federal and state governments. We also need to think about, we hear social determinants of health, right? But also need to remember indigenous social determinants of health. It is a Monday, feels like a Monday today. So those determinants of health, thinking about those economic factors, poverty and limited access to healthcare are significant barriers. Many Native people live in areas with inadequate healthcare services or have to travel long distances for those services. As I mentioned, that cultural disconnection, so disconnection from cultural practices and language has impacted mental and physical health. And in terms of health outcomes, we know in terms of life expectancy, Native Americans have the lowest life expectancy of any racial or ethnic group in the US. And I know that data showed here in Minnesota, the life expectancy gap between Natives and American Indians and our white counterparts is about a 10-year age gap. In terms of chronic disease, we know that Native people have high rates of chronic disease, such as heart disease, cancer, and diabetes. And in terms of mental health, we also have high experiences of mental health issues and substance use disorders. So with these in mind, it requires a comprehensive understanding of these unique experiences and social determinants of health for Native people. And it's more than just healthcare access. It's about restoring cultural identity, community connections, and really uplifting and centering tribal sovereignty.
Thank you so much. It's important that we think about governance in a holistic way when we're talking about how we provide adequate healthcare to Minnesotans statewide. I am seeing questions come in the Q&A, so no, we will integrate those into the conversation later. Senators Rasmusson and Hauschild, I would love to turn to you and hear a little bit about your experience in representing your districts. What are you seeing? What have you seen? What do you consider to be the biggest healthcare access challenges in your districts? Are there policy solutions you have been excited or energized or proud to work on, or something you're hoping to see realized in the future, whether it's in 2025 or beyond? Whoever wants to start is welcome.
Great. Yeah, it's a really good series of questions, Luna. I would say when it comes to what's the biggest barrier of access, and if, when I'm going around and talking to constituents, door knocking on the campaign trail, and when people bring up healthcare, the number one issue I hear about is cost. And so, they might even have a provider in town or be able to be referred to a specialist, maybe a short drive away, but they feel like the cost of healthcare is a barrier to them. And that could be whether they have insurance or they don't have insurance. But I would say that is something that, comes front of mind. And I would say another piece of it as well, from a public policy perspective, that I think is really important is, as we think about access, as we think about cost of care in particular, I kind of believe that, we're going to see healthcare costs continue to go up over the long run. And that's because as our economy is growing, people are going to spend more and more on healthcare services. thankfully, healthcare can do more now than they could 50 years ago. There's a lot of diseases, whether they be chronic or not, that now have more effective treatments versus before. 50 years ago, the healthcare industry couldn't do a lot for you if you got a certain diagnosis. So I think this cost concern is going to continue to be a trend both on individual patients, families, businesses, and for governments. And so we need to do everything we can to think about how we can effectively bend that cost curve while still ensuring high quality care. And some of the areas that I've been really focused on from a public policy perspective is looking at health occupational licensing reform. And so one bill that I worked on in the Senate, we had a lot of bipartisan support for it, and it passed the Minnesota Senate this year to get stopped in the House, was actually looking at allowing optometrists to be able to practice to the full extent of their training. And especially in rural areas where we might not have a whole lot of specialty ophthalmologists, allowing optometrists to provide the care that they learn about in school is really important for access. It provides more providers for the payers to go and contract with, hopefully, leading to more competitive rates for consumers and state governments. I'm a big supporter of the nurse licensure compact, especially bordering, having communities that border both North Dakota and South Dakota. I hear from nurses from hospitals all the time that they can have issues attracting nurses to Minnesota hospitals because of licensing issues between the states. And so I think, as we continue to look at what can the state do, I think it's removing barriers for health professionals to be able to do more of what they've been trained to do. And again, that'll help, especially in rural areas where, we're not getting any more MDs out in smaller rural communities. And so we have to find other professionals who are able to provide those services and those trainings. And I think that's one thing that we could do to move in the right direction.
Thanks, Senator Rasmusson, and I agree with you on everything you said. A couple of the big challenges that I see, first and foremost, is rural ambulance. We've seen really a crisis in my district in northern Minnesota, as well as Senator Rasmusson's district in central Minnesota. Him and I worked together this last session on an EMS aid package, as well as some pilot programs to provide a sprint medic where we can get medics directly to the door to patients to try to provide care on the ground in their home and then call an ambulance if it's necessary. So that was one piece that was really big for us to do. But again, we need our federal partners to step in and reimburse ambulance at a higher level with Medicare and Medicaid, given the older populations we have that are on those government programs. The other big crisis that I hear in everywhere, but in greater Minnesota, is the mental health crisis. We know that the distances that families have to travel to get the care for their loved ones for mental health and really any services are much higher when we talk about our rural communities. I have had a number of parents and in particular grandparents talk to me about sending kids out of state in order to get that care. I'm really proud of the work that we did during the 2023 legislative session to provide some funding to our hospital systems to address behavioral health, as well as some of the workforce incentives that we provided. But again, frankly, it was a drop in the bucket in the grand scheme of the crisis that we're facing in mental health, and there's a lot more work that we need to do. I'm excited about telemedicine and the progress that we've made in providing our rural communities telemedicine opportunities. This is huge, and we've been able to reimburse those services at an equitable level, but we are facing a cliff in that regard, both at the federal and possibly the state level. So we have to make sure that rural communities are listened to. We've seen the success. We've done the studies. We've shown that telemedicine can be effective. It's not everything. It's not going to solve every single health problem that we have. But when you're talking about the distances that I have in my district, the size of Massachusetts, some of the tribal communities in greater Minnesota that could access telemedicine to get the care that they need, there's a lot of opportunities with that regard. And I'm nervous, frankly, about what we have ahead of us in terms of making sure that stays where it needs to. And then lastly, I would just talk about the workforce. We know, Senator Rasmusson talked about we're not always going to have MDs, and that's exactly right. But we're also not getting the RNs, we're not getting the CNAs, we're not getting the nurse care workforce that we need in our nursing homes. So we have a fundamental workforce challenge statewide, but it's really, really acute in our rural communities for rural healthcare. So I would love us to see bigger investments in incentives for rural healthcare providers beyond just physicians. We did that a little bit with nursing, which I think was really good, but again, we need to do more. And then lastly, I'm aware of our medical school system in Minnesota being headquartered in the Twin Cities. It's a great program, but we need to make sure that we're having the residency programs in Greater Minnesota with our health system so that these doctors are not just getting the rural training they need, but perhaps are getting a life experience that might keep them in those communities. Or if a physician was raised in a rural community, they go and get their medical training at a regional campus like St. Cloud or Duluth, and then stay in those communities. That could be really, really critical for the future as well.
Thank you both very much. Speaking of mental health, we had an interconnected event earlier this year that was about suicide prevention, but with a rural cultural competence lens. And I learned a lot about that. And so I'm going to shift a little bit to have Dr. Henning-Smith speak about rurality and intersections with other identities and how that maybe provides an opportunity for unique and nuanced healthcare responses to certain challenges. A lot of your research in the last several years has focused on disparate health outcomes as it pertains to rurality, but also at the intersections with identities such as race, indigeneity, age, and disability. So what do Minnesotans need to know about unique challenges faced by those in rural parts of Minnesota when it comes to healthcare access, and how do those challenges shift uniquely based on other held identities? Huge question.
It's a huge question. It's hard to know where to start with this one, but it's such an important question, and I really appreciate you asking it. We're talking a lot today about healthcare access, but I think it's important to think about what the ultimate goal is. Why do we care about healthcare access? It's because we care about health outcomes and we care about ensuring that everyone has the opportunity for good quality of life and good health. And what we see in outcomes is that we have incredibly deeply embedded inequities in outcomes, things like life expectancy, rates of chronic conditions, maternal mortality. I could go on and on. I could list a lot of these. We see inequities between rural and urban residents, and we also see inequities that are rooted in structural racism. We see inequities that are related to sexual orientation and gender identity, to disability status, to income. I could also go on about that. But what's important to know is that when we combine identities at the intersection of those, we see the deepest levels of inequities. This is true nationally. It's also true in Minnesota. And sometimes I think in Minnesota, we don't recognize those inequities because our overall health outcomes are pretty good compared to the rest of the country. Healthcare access in Minnesota is pretty good relative to the rest of the country. And yet we have a lot of work to do. And we have deep disparities here in the state for both health outcomes and healthcare access that we need to recognize and address. There are many, many, many reasons why we have the inequities in outcomes that we have. Healthcare access is a piece of that. Along with the inequities in outcomes, we have inequities in access to health insurance and generosity of health plans. Some people on high deductible plans that feel somewhat meaningless when you need to actually get the care and you can't afford the deductible or the copay. We have inequities in accessing culturally appropriate care, in being able to see a provider who understands your lived experience. We heard a lot about workforce already. I just want to reinforce how incredibly important that is, and how not only do we need to think creatively about addressing our rural workforce shortages, but we need to make sure that we are supporting the growth of a diverse rural healthcare workforce to meet the needs of a diverse rural Minnesota population. We also need to think a lot about the social drivers of health, the social determinants that we talked about before. Some of the issues with outcomes that we see are related to inequities in housing, in job opportunity, in educational opportunity, in income. All of those are tied together in this really complex web with healthcare access and with healthcare outcomes. It makes it hard to know just where to start, and I think there are a lot of places we can start. I always see that as exciting rather than a limitation. There are ways we can impact health by thinking about quality of housing. There are ways we can impact health by thinking of quality of K-12 education or community and technical colleges in rural communities. All of these are important ways to start and important ways to address some of the inequities that we have.
Beautiful. Thank you for succinctly answering a huge intersectionality question. I really appreciate it. Dr. Hart, let's pop back to you. We're speaking in depth about rural geographic challenges in healthcare access, but what are some of the most important differences that we should consider between Minnesotans in rural and urban centers? We're getting a lot of questions in the chat, but one of them is about how health insurance is more expensive in greater Minnesota. Are there options? What are the things we need to consider?
Well, yeah, Senators Rasmusson and Hauschild and Dr. Henning-Smith did a very thorough job of addressing some of the differences, I think, between rural and urban centers in terms of availability. So I'll try to maybe reemphasize or touch on a couple that stand out for me. One is, I think, just the geographic barriers. Rural residents obviously, in many cases, live quite a distance from any sort of healthcare facility. I was just took it upon myself the other day in my 20-minute drive home to count how many healthcare facilities I passed, whether it be an office or an urgent care or a hospital. And I think in my 20-minute drive, I passed 16. In a rural setting, you might drive 50, 60, 70 miles and not see one. So obviously that lack of physical availability is a big problem. And one of the things we did that we're very proud of at Blue Cross is we pledged $5 million for a new rural behavioral health clinic in the Mankato area in an effort to increase physical presence as well as telehealth presence in that region. A couple other things I'll mention. One that I'm not sure has been mentioned or not, but I'll put it out there, is technology barriers. I think in terms of access to high-speed internet, broadband access, I am a huge supporter, like others on the panel, of telehealth and virtual health services. But, if you think about what about the individual who doesn't have high-speed internet? What do they do? And that's a problem I think we still have to grapple with, is how do we expand that access and availability? Workforce shortages has certainly been mentioned, as has economic variables. I think the last concept I might put out there is just the general health disparities that exist in rural settings versus more rural or more urban or suburban. We know, for example, rural residents are more likely to suffer from chronic conditions like diabetes, heart disease, obesity, just the increased incidence of those kinds of conditions is something we're very focused on. In 2024, for example, we expanded no-cost access to diabetes prevention programs for commercial members. We want to keep focusing on opportunities such as that to create more availability, more accessibility, increase the overall health of our rural communities. So.
Thank you. I want to piggyback on your comment about your commute and healthcare systems that you encountered during your commute, and ask our senators and Dr. Henning-Smith, if you want to hop in here as well, about transportation and what role it plays in equitable healthcare access. What have we got working? What's not working? What needs to be implemented differently?
And I'll talk a little bit about the work that Senator Hauschild and I did on emergency medical services. I think, one of the big points of feedback that we got as we were talking to ambulance providers across the state is that a significant number of the runs that they do are really for non-emergency calls. And oftentimes they're individuals who might not be able to drive, are having a medical issue that's very real, but it doesn't require an ambulance to come and pick them up and take them to the emergency room. It often, could be much more effective to have a nurse stop by and see what their needs are. Maybe they ran out of their prescriptions and they need to, get a prescription renewed. And so I think both from a perspective of those runs are very expensive for the system. They're very expensive, can be very expensive for the state. And for payers, I think we have to look at developing more systems, whether it's like the Sprint Medic model that Senator Hauschild talked about, or it's more of a community paramedic model. It's, having more of that primary care outreach. And then also looking at non-emergency medical transportation in rural areas is really important, because we can have, really beautiful, fancy hospital out in greater Minnesota that has all the latest, $1 million machines and, board certified MDs and all that stuff. But if someone can't physically get there, it doesn't do them a whole lot of good. And so it kind of goes back to the structural issue that we have in healthcare, where specialty services is where providers make money. And you look at emergency services, you look at, family medicine is not the moneymaker for a lot of these providers. Yet that's where we see this gap. That's where I think there's an opportunity to add a lot of value. And especially as we're looking from the state's perspective, that's something that I think about with our state Medicaid budgets. How can we better align incentives to actually provide better care, but also manage costs? Because it's really expensive to have that medical assistance patient wait until there's an emergency, dial 911, and then go to an ER versus maybe a more proactive approach. And so I think that's something too that I'm very interested in, is how can we have more aligned incentives between managed care and the state that could actually help bend the cost curve, but yield better outcomes.
The transportation issue is a big one. And I was recently talking to one of our physicians on the Iron Range, and I asked her, what do you think is the one thing that we could do to make the biggest difference in rural health outcomes? And she said transportation. And I'll be honest, I was a little surprised. I mean, I knew transportation was a big issue, but she sees it all the time. And I know in my former capacity at the Healthcare Foundation, the biggest thing that I raised money for were money for gas cards, for hotel stays, for a Ronald McDonald House in downtown Duluth to care for families that came from the more rural communities that had a child that was sick. All of those things are top of mind when you're considering, these life threats that you have, when you need to get to that regional hub for the care that you need and you can't afford it. We did in the last few sessions pass a bill that is going to create recommendations on transportation services, and that's coming in 2025. So I'm really anxious to get that report and some ideas on what we might be able to do with regards to some innovative transportation models. Senator Rasmusson talked about our EMS bill. One thing we did do in addition to that is travel to Washington, D.C. as an EMS task force to talk to our federal delegation about the need for both higher reimbursement for EMS in general, but also U.S. Senator Tina Smith has a bill that would provide reimbursement for non-transport. So those circumstances that Senator Rasmusson is talking about, when the paramedic gets to the home and discovers either A, the person's just looking for transport and it's not an emergency situation, or B, maybe it is an emergency situation, but that paramedic is able to resuscitate and give the care that they need at the home. We don't get reimbursed for that right now. And that is a huge disservice to our rural communities and our rural populations and our rural health systems when we're unable to get reimbursed for actually providing life-saving care on the spot. So I'm hopeful that Senator Smith will be able to move that along in the current Congress. We'll see. But those are some of the things that I'm looking at. I think this report coming in 25 will be really interesting as we go into the next session.
And I'll just add a little. I really agree with what both of the senators said. I think this is just a pernicious issue that's really, really hard to address. There's not an easy answer. If there were, it would have happened already. But I want to just reinforce the point that Senator Rasmusson made about non-emergency medical transportation. And I think we have a lot of challenges around emergency medical transportation, but those are just overshadowed completely by the size of the non-emergency medical transportation issue. And I would broaden that out even to say non-medical transportation. If we're thinking about health, if we're thinking about health outcomes, it's more than just being able to get into the clinic or the hospital. It's about being able to socialize, being able to get to work, being able to engage in civic life and in your community. And that's where we have just huge gaps in rural areas, and not gaps that were malicious, just the practical realities of disparate populations and small towns make it hard to serve really well. Many rural communities are served by public transportation, but they are, it's a patchwork system across the state that makes it hard to go from one system to another, to cross county boundaries if you need to. You're also often dealing with fixed route systems with limited hours. So if you want to go somewhere in the evenings or weekends, there are going to be limitations. And one thing that I want to raise up is the importance of volunteer drivers. And this is something that I hear all the time when I talk with aging service providers in particular. We have a real need for more volunteer drivers to help people get where they need to go day in and day out. Most of our volunteer drivers in the state are older adults themselves, and there are financial concerns around mileage reimbursement and whether that counts as taxable income and counts against Social Security benefits. So I think that there are potentially some policy fixes there. But with all of the issues that we have, volunteer drivers, I think, are going to continue to be really important to filling in some of the gaps. So doing something to bolster that group of people and to make that possible for them is really important.
That's a great action step for all of us, for attendees listening. I appreciate that you mentioned transportation as a means to accessing all the parts of our life that really impact our wellness. Ravyn, I want to turn to you with a question before we get to some audience questions, to kind of build on that a little bit. In your experience as a tribal liaison with the state, and also experience you have federally, what are some of the biggest access gaps for Native health and mainstream health systems? But also conversely, and from an abundance mindset, what can we learn from Native nations about healthcare access looking forward?
Yeah, absolutely. I think a lot of the gaps in terms of Native health and mainstream health systems have been, said throughout this panel, but of course, again, I cannot have to repeat, geographic barriers that remote area access to healthcare facilities, compounded by shortage of medical personnel in the regions. Thinking about funding and resource limitations, we know that the Indian Health Service is chronically underfunded, leading to limited services and longer wait times for care. Another result in inadequate healthcare for Native people. There's cultural competency. Some mainstream health systems often lack cultural competency, which can lead to misunderstandings and mistrust between healthcare providers and Native patients. Of course, again, economic barriers. We were just discussing transportation, not only travel, but rearranging healthcare or childcare and other costs associated with traveling to access healthcare. And of course, discrimination and bias. Native Americans often face discrimination in healthcare settings, which can deter them from seeking care or even additional care or follow-up. But what we can learn from our Native nations about healthcare access is five pieces I actually want to highlight. One is community-centered care. Native nations emphasize the importance of community involvement in healthcare decisions. So this approach ensures that services are tailored to the specific needs of that community, of that nation. Second is cultural competency. Native health systems prioritize cultural competencies, ensuring the healthcare providers understand and respect the cultural practices and belief of their patients. Three is that holistic health. So Native nations often take a holistic approach to health, considering physical, mental, emotional, and spiritual well-being. It's a comprehensive view that leads to better health outcomes. Four, self-determinations. Our Native nations advocate for self-determination in healthcare, allowing communities to manage their own health services and make decisions that best suit their needs. And fifth is the collaboration and partnership. So Native nations work collaboratively with other organizations and governments to improve healthcare access and outcomes. So I think by learning from these practices, mainstream health systems can work towards reducing disparities and providing more equitable healthcare for all.
Thank you so much. Several of the comments made today have highlighted trust, self-determination, trusted relationships. And I think that's really important for us to remember that beyond really tactical access barriers, transportation, insurance, things we might think of as more tangible, there's also like, if I don't have a trusted relationship or feel that I'm going to be trusted in my health journey or practice, I'm not going to access it. I maybe will choose not to access it. So I appreciate that. You mentioned community-centered care, and we have a question about anyone on the panel. How have you interacted with community health workers throughout the state? Have you made connections with community health workers to utilize them for care in rural communities, creating programs or partnerships with healthcare providers or nonprofits? Ravyn, we can stick with you if you want, because you mentioned that, but anyone's willing to hop in here. Excuse me.
Sure, I can answer this first. So at MDH, we offer a variety of initiatives that support community health workers. We offer scholarships and stipends for community health worker training programs and apprenticeships, working on infrastructure and sustainability planning. So collaborating with partners to build a sustainable community health workforce model, and of course, evaluation and measurement. So continuously assessing the impact of community health workers on health outcomes, specifically through my work as tribal liaison. We know that in tribal health systems, community health workers are often referred to as community health representatives, and they are an integral part to providing culturally appropriate care and improving health outcomes in our tribal communities. So key aspects of those community health representatives are those common cultural and language understandings of the communities they serve, which builds trust and understanding. There's that outreach and education. These community health representatives provide education, informal counseling, social support, and of course, that patient-centered care. They act as that liaison between community members and health and social services, facilitating access to care and resources, and of course, programs and partnerships. So including MDH, but of course, federally, the Indian Health Service supports community health representatives through various programs and initiatives to enhance community health.
Great. Anyone else want to speak to your experience with community health workers or opportunities for that integration, particularly maybe where we're seeing provider decreases?
I was just going to mention a little bit of a diversion from community health workers, but we really prioritize the utilization of peer specialists in the behavioral health world. These are individuals who go through training as a member of the community, who have had former experience with mental health or substance dependence conditions, and can come alongside others who have those conditions, help them navigate the complexities of the healthcare system, help them with coaching and sustaining the gains they've made in treatment. So we have a strong commitment to that model.
Thank you. Senator Rasmusson, there's a question for you about your background in private equity. The variety in firm goals and priorities, given the variety in firm goals and priorities, how can the healthcare community ensure that investment in rural clinics maintains a patient-centric approach? Any thoughts on that?
Yeah, thanks, Luna. And thanks for the question. I think an important principle for healthcare is if we artificially, and sometimes this happens at the legislature, if we artificially try to prevent competition in healthcare, we tend to get higher cost and lower quality. And I would say whether you're looking at occupational barriers, whether you're looking at hospital moratoriums or other things that prevent providers from entering a market, whether you prevent certain types of capital, whether that's private equity or others, from entering into markets to provide services, I think the outcomes that you see are higher costs and reduced quality. And when we're talking about the workforce issues we're facing, provider access issues, cost issues, we want to try to encourage more providers, different types of business models to come into this place. And I would say, like, you look at some of the solutions that we're talking about, whether it's on biotech and amazing innovations that are curing diseases, a lot of that's driven by public and private markets. You look at the advances that have been made in telehealth. A lot of those investments are coming from the tech sector. And so I think we have to be really careful about trying to restrict who can participate in these types of systems. And I think when the state has done that, we oftentimes will end up with a lack of providers and higher cost and lower quality. And so I think we need, whether it's nonprofit, for-profit, provider-driven, I think we need all these models to be successful. And ultimately, if we provide choices to Minnesotans in terms of where they go to receive their services, they're going to be able to make the best outcome, the best decisions for them and their families. But it's a great question, I think. And if you look at some of the alternative models, like if we look at the National Health Service in the United Kingdom, as example, I mean, waiting lists for that system can be 18 months or longer right now. And it really, so even though there can be trade-offs with different systems, I think it's important for us to look at those trade-offs, think about what we want from our healthcare system, and how can we align incentives to best get it. But at the end of the day, if we're going to kind of just have a government takeover of the healthcare industry, I don't know if that would give Minnesotans the outcomes they want either. That's a great question. Thank you for asking.
Someone's wondering if you think removing regulations would lower costs.
Yes, I think in some ways, especially when you look at what happens with providers and kind of restrictive laws that prevent healthcare professionals from practicing what they've learned in school, I think that drives up cost. I also think policies like the hospital moratorium, where you can effectively have incumbent providers box out potential competition. That is an issue. We have to deal with it at the legislature on a regular basis, including passing a moratorium against having more children mental health beds. That took an act of the legislature instead of just a provider seeing a need and being able to go meet that need. So I think when we put in artificial barriers to competition, we have higher costs and lower quality.
So I want to move to Senator Hauschild, you unmuted. If you have like a 1 minute response.
I do. So I think Senator Rasmusson, I don't necessarily disagree with him with regards to regulations that get in the way of reducing costs. However, I do want to make the case that there is a point for targeted and purposeful investments when it comes to rural healthcare. If we just leave things to the market, we know that rural communities will get left behind. We know that communities like our tribal nations would get left behind. Our populations are aging. Our populations are decreasing. The distances that we're impacted by, the fact that our EMS licenses are being held by our local communities that go on property tax owners who are already on fixed income compared to wealthy areas like the suburbs where it's private providers. All of these things compound on our rural communities when it comes to well-being and health outcomes. So there is a purpose behind making sure that we're doing these targeted investments. And I don't think Senator Rasmusson and I disagree on that, but I just think we do need to make sure that we understand regulations do and targeted investments do have a benefit when we're talking about rural disparities as well.
Thank you both. I just want to uplift all of the questions and commentary that are in the Q&A section. I will send this to all of our panelists so you can be considering these things in your work moving forward, but a lot of questions about finances, about federal systems potentially being defunded and what that means for Minnesota, cost of prescription drugs, maternal health care. So know that all of those are coming. And I feel like, yeah, we should have Mind Opener 2.0. It's 101. If I could ask as a close that everyone give a short, what might be to you your most important first step for Minnesota policy and infrastructure to combat geographic disparities in healthcare access that might be related to your work? High-speed train, coverage, incentives, reimbursement, statewide health system. What's your closeout? Dr. Henning-Smith, you're to my right.
I'm just going to mention medical debt because we haven't talked about that yet, but it impacts 40% of all Americans, and we're making some exciting progress on that here in Minnesota, but I think we need to continue to address the issue of medical debt and how that impacts access and outcomes.
Thank you. Dr. Hart, how about you?
Hard to pick one. I would go with prevention and screening and prevention. I think if we look at our healthcare system overall, it's really designed to address sickness versus keeping people healthy. So I think the further we can move down the road of keeping people healthy, the better off we'll be.
Great. Ravyn, how about you?
Yeah, I agree. Hard to pick one, but I would say I think in terms of Minnesota policy and infrastructure in relation to tribal nations is really to empower tribal nations to fully utilize their public health authority. By recognizing and supporting the sovereignty of tribal nations, Minnesota can enable these communities or nations to tailor healthcare solutions that address their unique needs and circumstances.
Thank you. Senator Rasmusson, you're next on my list.
Thanks, Luna. I would say health licensing reform. It's a way to increase access in rural communities without putting additional burdens on taxpayers.
Thank you. And Senator Hauschild. Maybe we lost him connection-wise. I don't see his video. I want to thank all of you for this robust conversation and for the work that you're doing for Minnesotans every day. Thank you to our panelists for this hour, but also for all the time. And thank you to all of us, thank you to all of us in this room together on Zoom. Thank you to all attendees who joined today over the lunch hour. The recording will be up shortly, and please continue to join us for conversations about diverse perspectives on policy issues, 2.0s. Let us know what you want to see, and we appreciate you being part of civic community. So thank you, everyone. Have a good rest of Tuesday.